Now it's on.
I would have put lipstick on. I forgot my eyeshadow.
Okay.
Are we good?
Yeah.
Oh, am I being recorded?
It's
My
very
lipstick, my admitting to wearing lipstick is just being recorded for the history time.
It's
Okay.
in the way, no?
Yeah. I'm Ben Thomson. I'm one of the new nephrologists here. My favorite color is blue. And I was asked to talk to you about calcium, phosphate, binders, all that stuff today. Is there anything else that we normally introduce ourselves with? I guess
That's good.
I'm from Western Canada and I like Calgary Flames and I don't like the Leafs. If that is a thing.
That's good.
So I've done this talk twice before. I've updated a little bit with some of the slides towards the end. But ultimately the question that everyone sort of asks going around the unit is, why do I need to take my diet? And maybe Jenny's in a better position to answer this than I am, but I'm going to talk from a nephrologist perspective why we think it's really important to have our patients take their binders and physiologically what is actually at play here. So because it is an academic activity, I do have to declare that I don't have any conflicts of interest, and I have received research money, but none to do with any of the drugs I'm going to talk about today. A few things I want to go over today. So really to understand why we take binders, we have to understand the physiology and the pathways involved in why are calcium and phosphate levels tightly controlled in the body. Okay, so how does that work? Why does kidney disease disrupt these mechanisms? So why do all our patients on dialysis have high phosphate levels? Why does that happen? I'm going to go through different classes and types of phosphate binders and why we might use one in one situation and not in another situation. And then at the end there's a little quiz. Because if I look around and see that you're all falling asleep, you'll get 0 out of 2 on the quiz. Alright. So this is really how I'm breaking it down. Okay, we'll talk about plasma calcium concentration. If you think of everything on the dialysis unit as all the phosphate talk is really about calcium. Okay, so calcium really triggers PTH, high phosphate triggers PTH, but really if we think initially as a low calcium as the precipitator, that sort of puts everything in context and gets that understanding started. I'll talk about phosphate binders, vitamin D, cinacalcet, some of the controversies, because I'm pretty sure if you had this talk by a different nephrologist, some of the information would be presented a little bit differently. I can say that in the United States, our practice is very different than here. And in Europe, our practice is different than in Canada as well. So there's a few things that are different that we should probably touch base on. And then the cases, you'll have your quiz. Okay, so how does plasma calcium concentration get controlled? Okay, really, let's just imagine between 2 and 2.5 is the normal serum plasma concentration. And let's just say we have someone with 1.8, okay? So we're going to start off with hypocalcemia, okay? So here we have a blood vessel and someone for whatever reason, as a given, has a low calcium level. So what's the first thing that happens? That is detected by the calcium sensing receptor. And where is the calcium sensing receptor? In the parathyroid glands, exactly, okay? So the first thing that happens is the calcium sensing receptor detects low calcium in the parathyroid glands. And the parathyroid glands are shown here in the blue, and that red stuff is the thyroid gland, because you have 5 parathyroid glands, 4 or 5, 2 on either side, and sometimes there's also 1 in the middle, okay? Now the parathyroid glands secrete a hormone called parathyroid hormone, okay? This is pretty easy stuff, okay? Otherwise abbreviated as PTH, okay? So you can see already low calcium eventually leads to increased PTH. I didn't draw it here, but the other stimulus for elevated PTH is high phosphate. So both of those things trigger PTH secretion. Now I've drawn you 3 organs here: bones, kidneys, and small bowel. And as it turns out, for the sake of the PTH discussion, those are the 3 organs that are most important for the subsequent actions of parathyroid hormone. what happens in the bones? Because there's parathyroid hormone receptors in the bones. What does that cause in the bone? I have lots of PTH. What do the bones do with PTH? What do? They release calcium. So, and they do that by resorbing bone. And resorbing bone means breaking down bone, essentially. So if you break down bone, the major constituents of bone are calcium and phosphate. So if you're breaking down bone, not surprisingly, your blood levels of calcium go up, your blood levels of phosphate go up. Okay, and you can see it actually makes sense because you started this process with low calcium, PTH increases calcium, you're hoping that corrects. Makes sense, right? Similarly, in the kidneys, and let's just assume you have normal kidneys for the moment, okay? We're just going to make that assumption straight off the top. If you have normal kidneys, you have low calcium, what makes sense for the kidneys to do? To reabsorb calcium. So you're peeing out less calcium. And that's precisely what they do, okay? It's precisely what they do in normal situation. But I didn't draw phosphate here. Why didn't I draw that? I didn't draw it because, quite honestly, if you have high phosphate, triggers PTH, but the bone increases phosphate in the blood. So if anything, it's actually making it worse. So then the kidneys are really the only organ there that can correct it by peeing out more phosphate. So they decrease reabsorption of phosphate. So if your phosphate is high, you have PTH secreted, the kidneys pee out more phosphate. That's the corrective mechanism. And that's the only way you can get rid of phosphate. Okay, so what's the next step here then? The next step is actually in the small bowel. So PTH, if you take vitamin D, there's 2 steps of activation. So the stuff you buy in the pharmacy that's just plain old vitamin D, 1,000 units, it needs to be activated. First by the liver, and then by the kidneys. That second step requires PTH, okay? It requires a hydroxyl group added in the kidneys, okay, at the 1 position. So when you hear of 1-alpha, okay, there's 2 kinds of vitamin D. There's calcitriol and there's 1-alpha. 1-alpha, what it's done is it's taken this vitamin D, it's added the 1-hydroxyl group, so that it just goes through the liver, it adds a 25-hydroxyl group and it's activated. So it does the kidney's job for it. If you have calcitriol, calcitriol is basically this. So it's bypassed this step and bypassed this step. Okay, so it's active. So what does vitamin D this do? Well, this is what it does, okay? It allows the small bowel to reabsorb more calcium and to reabsorb more phosphate. So let's go through this again on a table, okay? So if I say to you, okay, we have low calcium, okay? Low calcium, what's going to happen to PTH? It's going to go up, right? In the kidney, you're reabsorbing more calcium. That makes sense. That corrects the calcium. In the bones, you're resorbing more bone, so you're going to release more calcium. That makes sense. That's going to correct your calcium back to normal. Vitamin D is going to improve small bowel reabsorption of calcium. Excellent. Calcium goes up. So if you have low calcium, PTH works perfectly. It corrects your calcium. It's perfect. But what if you have high phosphate? What's the problem then? High phosphate also triggers PTH, which means if your kidneys are working, you excrete more phosphate. That's great. Your phosphate in the blood goes down. But you still resorb more bone, meaning it's driving your phosphate up. And you still have more absorption of phosphate in the gut. So high phosphate, pretty much the only way you can get rid of it is the kidneys. That's it. It's the only way. You're not going to get rid of it if your vitamin D is activated, because you're just going to reabsorb too much in the gut. Okay? So therein lies the problem. If my phosphate is high and my PTH is high, the only way that I'm going to drive my phosphate lower is what? That's it. It's the only answer, right? You got to poop it out. So you can't take it into the gut, and when it is in the gut, it has to bind something, so you poop it out, because you don't have the renal excretion, right? So that's why we have binders. The only way to get rid of it is through the gut, and so we're accentuating that. there's two main classes of phosphate binders. We break them down on the basis of whether they contain calcium or whether they don't contain calcium, and I'll explain why that is. Calcium-containing ones, there's a whole bunch of them that we know. Tums are the ones that some centers literally you'll see every month at blood work rounds, the nurses go around and give a container of Tums and say, you're not taking these, you need to take these home. Right? And that's part of the care of patients with kidney disease. So that's, sometimes they'll take Tums. Apocal is another one. Calcium acetate is actually a little bit more effective at binding phosphate, phosphalo. It's not one we see as often used in Canada. And then there's the non-calcium containing ones. And I've put 3 of them here. The very first binder that was popularly prescribed was actually Alugel or Basal gel. It was an aluminum containing binder. It works very, very well, but has many problems that I'll talk about in a bit. And then Renagel. Renagel has a lot of trials. I'm going to go through a few of them. In fact, as far as the non-calcium containing phosphate binders, probably has the best evidence for use compared to the other ones. Okay? And then lanthanum. So this is just a table summarizing all of them. You can see the calcium containing ones are at the top, the non-calcium containing ones are on the bottom. You can see there's a few very clear advantages to the calcium containing ones. They tend to be less expensive than sevelamer and lanthanum. Okay, that's not surprising. As far as efficacy, and by efficacy I mean as phosphate binding capacity, okay? You can see the aluminum ones are really good. Calcium carbonate not as good. Okay, so per pill it doesn't bind as much phosphate. It's generally thought to be less effective at binding phosphate. All of them have GI side effects. They all do. Okay, so there is a concept that, oh, they're on Tums, they're getting a little bit of GI upset, they're getting a little bit of bloating. I'll switch them to Apocal, or I'll switch them to sevelamer. And sometimes it works, but to be honest, they all have GI side effects. They all change the taste of food. They all do that. So bottom line, if you're thinking of the calcium ones, you're going to do it because it's cheap. Okay, that's the major reason. Do have a little bit of side effects. And as far as efficacy goes, we don't prescribe a lot of calcium acetate, but it would be one that's probably more efficacious than the calcium carbonate. When you look at the disadvantages there, contains calcium. Okay, so obviously the calcium-containing ones contain calcium, and that is a huge disadvantage. Why do you think that's a disadvantage? Why is it a problem giving dialysis patients calcium?
You can't get rid of it.
Well, they can't get rid of it, that's one. But what's the major cause of death in dialysis patients?
Hardening of the arteries.
So cardiac disease, right? Yeah, and so I'm going to show you why the calcium is a problem on the basis of a couple studies. Aluminum toxicity. Has anyone seen aluminum toxicity? Okay, I'm going to show you what that looks like, because that's something that's a big problem. Sevelamer has an additional advantage. It actually improves your cholesterol. Whether that leads to any improved outcomes is still controversial, but it appears to improve your LDL cholesterol and your total cholesterol. Okay, so let's go through a couple of these things. Specifically, I mentioned aluminum toxicity, but didn't go through it, and really, why is containing calcium a big disadvantage? So we're going to talk about those things for a bit. Before we get to that, I want to talk about vitamin D compounds, because it's important we understand this pathway. When you buy the vitamin D 1,000 units in the pharmacy, your liver needs to work and your kidney needs to work for that to become effective. If you're someone with cirrhosis, you're not activating that. If you're someone who's on dialysis, you're not activating that. So generally, you'll notice that a lot of patients are on 1-alpha or calcitriol. We don't use a lot of 1-alpha here, but the 1-alpha, if you had 1-alpha, basically you've done the kidney step for the person. You've added the 1-hydroxyl group. Their liver still needs to work to add the 25-hydroxyl group. So 1-alpha, you still need a liver that works. Okay, so as you can see, if you're someone with cirrhosis and you give them 1-alpha, what's going to happen to that? Nothing. It's going to remain inactive, and they're going to do absolutely nothing with it. Okay? So what would you give someone with cirrhosis? What type of vitamin D would you give them that has the 25 and the 1-hydroxyl step already done for them. Calcitriol, yeah. So centers that use 1-alpha, and we're not one of them, London, Toronto use a little bit of 1-alpha, those centers have to be very cautious that they are making sure that patients don't have cirrhosis, okay? Because those patients, it'll be ineffective, and they'll have to use calcitriol in those patients, okay? Ultimately, what happens is once it's been activated, once the vitamin D is in an active form, either as calcitriol or 1-alpha that is gone through the liver in someone with normal liver function, okay? That vitamin D, remember, it works mostly in the bowel to reabsorb calcium and phosphate, but it has a feedback mechanism that shuts off PTH. So you'll see patients that we often, as nephrologists, start these calcitriol or vitamin D substances. One of the things it does is it actually decreases PTH. So in the patients with really quite bad secondary hyperparathyroidism, where the PTH is really high, one of the ways we can bring it down is by giving them vitamin D. Okay? Aluminum toxicity. So this is something we don't see very often. There's two theories as to why aluminum toxicity exists. One of them is that we used to use a lot of the Alu-gel and aluminum-containing phosphate binders. The other is that aluminum is actually in water. So if you go home and drink a bunch of water from the tap, you're actually taking in a fair bit of aluminum. And it's also in the calcium-containing phosphate binders. There's some aluminum impurities that you take in. So you actually find it in a variety of sources. Ultimately, there's no way to get rid of it in patients with kidney disease, so it just builds up and up and up and up. If you're giving aluminum to bind phosphate, it'll essentially go up and up and up, okay? And in these patients, once it's over a certain level, they're at risk for a number of manifestations that we rarely see. But these patients can present quite delirious, encephalopathic, and in fact, if they've had high levels for a long time, it can be permanent, those changes. They can have dementia. It's considered one of the potentially reversible types of dementia. Dementia is usually considered permanent, but interestingly, in patients who have it because of aluminum, you can see if you bring their aluminum levels down, you'll find that they actually improve. So it's something that we might want to think about in our patients. If they present with a new onset delirium or dementia, you might want to check their aluminum levels.
We check them every year.
Yeah.
Everybody.
So if you had someone, I'm sorry for interrupting, if you had someone on an aluminum-based binder like sulfur or something like that, is it not part of our program that we check their aluminum levels more frequently?
It is, and in fact there's cutoffs when the aluminum is over a certain level in the blood, we should stop it. I'll go through the guidelines for aluminum binders because in fact they're different depending on whether you're in Europe or the United States. But generally they do argue that if you're using aluminum, you should either not use it at all or use it for a short period of time. It shouldn't be something that a patient is on for a long period of time.
I just have a question about that.
Yeah.
If somebody's on something like an Ovol, like aluminum hydroxide, like they don't tend to take it regularly, but should we be bringing up the idea of testing aluminum more often in those patients?
If it's an aluminum-containing binder, absolutely. These
It's
patients
not a
should be.
binder, like an Ovol, like something to help with gas.
Oh, like Malox, like something like Malox,
Yeah.
like magnesium. Yeah, I mean the aluminum levels should be checked in those patients because they do absorb aluminum. So Malox is a classic one. No one really knows what Malox is. Well, it's magnesium and aluminum hydroxide, right? So that contains aluminum. We absorb it, and in fact, they can get hypermagnesemia as well as high aluminum. So any substance that contains a lot of aluminum, we should be checking levels in because they're susceptible to this.
I thought Wobble was simethicone.
What's that?
Are you talking about Wobble, Jenny?
They take it for gas pains.
Yeah.
Like
So
Malox?
it's
It's a pill.
simethicone.
Or-
It's which?
Simethicone?
I don't. What's the
know
pill
what's
called?
in it.
Omicron?
Ovol, and it has aluminum hydroxide in it.
OVOL.
Yeah.
Yeah.
I mean, if it's got aluminum hydroxide, you absolutely should be checking. Yeah. So in addition to the central nervous system side effects, you can see the bone typically presents with diffuse bone pain. Often these patients are thought to have malignant cancer. because they're just pain everywhere, and oh, they must have multiple myeloma, or they must have metastatic prostate disease. Well, no, they have osteomalacia, and that presents with diffuse bone pain, and that's due to aluminum replacing the calcium in the bone, and it causes pain. Because of the replacement of aluminum within the bone marrow fails to function appropriately, and they don't respond to EPO as well. So if you have a patient who's on an aluminum-containing drug, and you see that their EPO requirements have gone from 5,000, 6,000, 7,000, 8,000, 9,000, 3 times a week, you might actually check their aluminum levels, because their lack of response to EPO may simply be that their aluminum levels are shooting through the roof. And then there's some other less common jerky movements and weakness that patients like this can get. So that's what aluminum toxicity typically looks like. Now, this is controversial, what I've put up there. Normal people, meaning anyone who has normal renal function, okay, it would be expected that the levels would be under 20 micrograms per liter. In patients who are on dialysis, the normal range is actually higher than someone with normal kidney function, because they'll be exposed to aluminum in all walks of life and different types of foods and other things. So the normal level in someone under dialysis is actually 60. So if you order aluminum in a patient and it comes back, ooh, it's high, it's 40. For dialysis, that's actually probably normal. It's actually considered normal. And they won't actually generally get symptoms unless it's over 500. Okay, so even if it's above the goal level under 60, if it's a couple hundred, it's probably not going to be a big deal. And 500 is controversial, depending on the source what you read. Some say over 1,000, some say 500. So I've put the more conservative estimate of 500. Okay. What's the disadvantage? Okay, so we decided the cause of death was cardiac. Okay, so what kind of cardiac death do these people have? Are they dying from heart failure? Are they dying from MIs? Are they dying from sudden cardiac death? Are they dying from, what are they dying from? Sorry?
Bad valves.
Bad valves, yeah, I mean that's a contributor. But the major cause of death is sudden cardiac death. Okay, that's the major cause of death. And we know that these patients have very poor vascular compliance. So their blood vessels don't work as normal blood vessels do. So on a population scale, sudden cardiac death, why do most people die of sudden cardiac death? On a population basis, what's the most common cause? So outside of our dialysis population.
Sudden cardiac death.
Yeah, it's heart attacks, right? Yeah, coronary artery disease, that's the #1 cause. And I'll tell you, it's not that in our patient population. So if you think of coronary artery disease, and you think of a blood vessel, you have 3 levels of a blood vessel. You have the inside, you have the wall, and you have the area on the outside of the wall. Any of us in this room with normal kidney function, if we get a heart attack, it's because on the inner part of the wall we have a thrombus or a plaque, okay? And that obstructs the lumen, obstructs blood flow. Where do dialysis patients get their blockages? Where do they get their deposits?
The middle.
In the wall. Yeah, so they get it in their wall, in what's called the tunica media. And because they get it in their wall, their blood vessels, rather than closing and opening like normal blood vessels do, they don't work as well. They don't comply. So when they need to close, they can't, and when they need to open, they can't. Okay? So that's part of the problem. So this is, again, cause of death. Cardiovascular is the most common. The tunica media is calcified. So it's actually calcium. If you look at the reason there's blockages, it's calcium phosphate deposition in the tunica media. It's a major problem in these patients. So there's a burden of calcium being deposited in their walls. We know, if we take on a population basis, if you look at phosphate levels in the general population with or without kidney disease, we know that the higher the phosphate level, the higher the likelihood of death. Okay? And that's in and out of the dialysis population. We also know that if you do the same thing, if you take the calcium level and multiply it by the phosphate level, that together also predicts death. The higher that is, the higher the likelihood of death. So our thought is, well, giving calcium is going to increase this. it's going to increase that. Are we actually increasing the likelihood of death in these patients by giving them calcium binders? It's a good question. Could it be that by giving them calcium, we're making those blockages inside the blood vessels worse? We're making that calcification worse, and that's entirely possible. And that's the concern by giving them calcium, right? There was actually wasn't that long ago, but when I was a trainee in nephrology, and I was where you're sitting, the staff who talked about this said, this is all nonsense. It's all nonsense. It doesn't matter if you give these patients calcium with food, they don't absorb the calcium anyways. Their calcium levels won't go up, they'll be fine. It'll just bind the phosphate, they'll poop it out. But we know that's false. And in fact, they knew it was false then, because if you randomize patients to taking calcium with food or nothing, even when they take it with food, their serum calcium levels go up by about 0.1 to 0.15. And that's from every trial that's basically been done has shown that. So we know that's not true. So we know that even when you take it with food, taking calcium will increase your calcium levels in your blood. So very clearly there's the major concern, are we actually driving sudden cardiac death with these patients? So what evidence do we have? And there's a few pretty important trials about this. So we know that if you take sevelamer, okay, if you take patients who have pre-existing calcification, okay, and you randomize them to taking calcium-containing phosphate binders in one group or sevelamer in the other group, and you do before and after calcium scores in their coronary arteries and in their aorta, sevelamer looks to have lower calcium scores, okay? So basically, if you give calcium, you have higher calcium scores, and if you give a drug that doesn't contain calcium. And those calcium scores are actually correlated well to death, cardiac death. So probably that's important. So this doesn't tell you that giving sevelamer decreases death. It just tells you that it decreases the amount of calcium. So it'd be nice if you had something that says, yeah, well, the cardiac death is better. But instead, we're looking at an outcome that is correlated to something that's correlated to death. So it's not a direct measure. It's, you know. We also know from a couple randomized trials that if you start the trial with calcification, so if I do an x-ray on these patients, or I do a calcium score on these patients before I decide what binder to put them on, and I determine that you have coronary calcification, if I have a decision, if I have 100 patients like that, half of them I give calcium-containing binders, half of them I give sevelamer, the calcification gets worse in the patients who get calcium. We know that as well, okay? And that's been shown pretty convincingly in a randomized trial. So this part is majorly concerning. So if you combine a whole bunch of trials that have looked at sevelamer, and you've looked at sevelamer or calcium-containing binders, in patients who have calcification at baseline, if you give them calcium-containing binders, they have a higher risk of death. That's a pretty important outcome. But the problem is that that's not a randomized trial. A lot of these were observational data. There was a lot of adjustments to the data after the study was done. So a lot of people looked at that data and they weren't particularly happy. You know, they said, well, after all these adjustments, it increases your risk of death by about 3 times, but you made too many statistical changes, so I'm not really sure I believe this data. And so still, most people will still tell you, well, you know, calcium's still probably the best first choice for people. If you have a choice between giving people binders or no binders, we know that if you get nothing, you have a higher risk of death. If you get something, you have a better chance of surviving. But again, that doesn't answer the question, calcium versus non-calcium. It's, you know, it says we should be doing something, but it doesn't tell us which one we should be doing. So I'm going to leave the last bit. Up to about 2013,